Okay, so before we start, right, I thought it would be nice to do like a recap of what we have learned so far, like as a just as a revision of what you all just learned. Okay, so first, these are the important things that you need to capture from Akira's presentation. I was preparing it while he was teaching. So this is the first thing you all need to know, the entire axis, memorize it and know what controls it, what is the negative feedback. Then remember after that we talked about primary and secondary hyperthyroidism, the difference between the two, what TSH and T3, T4 levels you expect. And remember how I talked about how the T3 and T4 is an independent variable and then the TSH is the dependent variable. And if you all are interested, there's actually the reason why the T3, T4 is the independent variable, right? It's because of this log linear relationship. But I leave you all to read it on your own. And this one I'm not very sure whether it's still like the current explanation for it, because honestly, like the explanation for this phenomenon keeps changing like with time. But this is what the prof taught us last year. Okay, then remember we talked about this thyrotoxicosis versus hyperthyroidism. This is the formal definition. So thyrotoxicosis is the clinical state where you have high circulating T3 and T4. They can be endogenous or exogenous. So some cases where people will take like thyroxine, right, is people who like try and do weight loss. Then those weight loss tablets, especially the illegal ones, they usually contain thyroxine inside because it makes you like increase your basal metabolic rate so you lose weight. Okay, and it can be quite dangerous. And then I'm not sure whether you all still have this diagram inside your notes now that you all changed lecturer, but make sure you know the whole pathway of how T3 and T4 is manufactured. What are the important enzymes, especially the enzyme called thyroid peroxidase. And why that is important is because in Graves' disease, in Hashimoto's disease, in Hashimoto's disease, antibodies against your thyroid peroxidase enzyme is what causes the hypothyroidism, because you impair the T3, T4 like production. Makes sense, right? Okay. After that, this picture was drawn by Gladys last year. So we talked about this bitemporal hemianopia thing. You all will learn this more in your CNS module after CA3. But I'll just leave this diagram here for your reference next time. So like this is the entire visual pathway, and where the pituitary sits, right, is actually just beneath this optic chiasm. So you can imagine, and then below this pituitary gland, right, is the nose. So you can imagine that when the pituitary expands, right, it can then compress onto the optic chiasm, and then it will cause the bitemporal hemianopia. We also talked briefly about hyperthyroid versus hypothyroid. In summary, one is fast, high, and inefficient. One is slow, low, and inefficient. Okay, and then this is just a diagram for your reference, right? So actually, the optic nerve, optic chiasm is here, pituitary is here. So this is what I was talking about when it expands, like in the pituitary adenoma, especially those that are secretory in nature, right? And they grow bigger and bigger, and they will compress onto the optic tract. And so the surgical intervention is usually to go through the nose, up the nose, and then cut a hole through the skull, and then access the pituitary there to take it out. Okay, and then this was the picture lah. So when we look at this, is an MRI scan, right? And how we know? Yeah, it's an MRI scan. How we know it's an MRI scan, right? Versus CT scan. This one, do you all know? MRI versus CT, how to tell the difference? You all have been through imaging lectures, right? Okay. In CT scan is using X-rays, right? Bones appear white. In MRI, bones appear like grey kind of thing. Okay, but in CT it appears bright white. So over here you look at the skull, right? This is not the bright white that we are expecting to see. MRI is used for like to visualize soft tissues. CT is more useful for bones and bleeds. Okay, so this is just some principles, and then usually we will compare to the normal picture, and then we look for abnormal signals. So abnormal signals, it can be either very bright or very dark, and indicate some kind of abnormality. Then this is something that you all should be familiar with, the histology of the thyroid gland. Make sure you know the different kind of cell types, the follicles, parafollicular cells, and what they secrete. And then remember, the pointer is actually pointing to your blood vessel. But this is one typical example of a thyroid follicle, another thyroid follicle, another thyroid follicle. And why you need to know your histology well, right? Is because in M2, when you do pathology, everything correlates back to histology. Because cancer always arises when one particular cell type starts growing abnormally, and then the entire lineage is abnormal. So you look at the architecture of the cells. So knowing what normal looks like and how the cells are arranged, right, is important. Okay, and again, you see this you should be able to correlate this picture, this diagram, to this one, right? So lining the follicles, right, over here, these are all your cuboidal or squamous cells. So if it's active in production, it's columnar. If it's inactive, then it will become squamous . yeah, a more zooming view will give you a better picture. But so again, these are your columnar cells. Then they produce the thyroglobulin, right? The colloid material that's inside here. So this thyroglobulin production, right? The colloid material is what all these big pools of mucin are. These pink pools of mucin. Can I hope this is not foreign lah. Okay, so now we go to case number 7. We are jumping a bit. So like initially was supposed to be Bottle do first, but then Bottle like got something on now. So like I do the more vomiting first. After that, he will give you the vomiting. Okay, but this is going to be quite a difficult case because it's an integration of everything. So there's biochem, there's patho, and there's there's biochem, there's physio, and then there's like just integration of metabolism. So everything is there lah. So it was quite a challenge to prepare. These are the things that I expect you all to have studied or read about already. So I'll leave this here for you all to refer to if you all need to look through your sources lah. Okay? Because I tried as much as possible to take stuff from your slides so that you all can correlate. Does it look familiar to you? Yeah, this is Kenneth Ban. Okay, so what I want to point out here, right, is anabolic and there's catabolic. Everything in biochemistry can be organized into these two kind of processes. So anabolic is to do with storage and biosynthesis. So for example, in a fat state, then certain regulatory hormones are secreted to enable me to store all the excess glucose, and at the same time to take the excess glucose and to synthesize new compounds. When I'm in the fasted state, in the hungry state, and I have not enough glucose, then I need to oxidize and metabolize all these fuel stores, break them down so that I can create energy. Alternatively, I can also break down my skeletal muscles, break down my other structures in the body to form energy. So these are catabolic pathways, anabolic pathways. Okay, understand? Quite clear. Okay, so in that case, then we're going to do the first Kahoot. Okay. Do you want the music or like don't need the music? It's fine. Okay, can. Okay, are you all logged back in already? Can Okay, so which of the following does not occur in the fed state, generally speaking?
Oh,
The fats.
We're not working. We're not working.
Okay, 7 seconds left. You all just choose something. 3 people, 4, 2 seconds, 1 second. Okay. Who's?
I cannot press.
You cannot press.
I also cannot press.
Oh man. Okay, never mind. We shall continue. Okay. So the question was which of the following does not occur in the fed state? So in the fed state, I just had my meal, right? So what happens when you just ate your meal? High insulin. So insulin secretion. Insulin is secreted by beta cells of pancreas, correct? So you always don't talk about insulin in isolation. You must always talk about the insulin glucagon ratio. So this is how you must present your answers if you write an essay about it. So in the fat state, there's an increased insulin glucagon ratio. So this actually leads to the activation of all the catabolic pathways. So catabolic pathways are those for biosynthesis and storage. Remember, biosynthesis and storage. So in the fat state, I activate all the catabolic pathways. At the same time, so that I don't like act against myself, I deactivate all the anabolic pathways. So only one of them predominates at certain points. Anabolic is like fuel oxidation and detoxification. Let me show you.
Catabolic is break.
Sorry. Okay. I don't balik anything.
I saw you all chose the blue color.
I can't click.
Okay. So my question is wrong.
I thought,
Huh? Really? Okay, wait. Where's my mouse? I'm confused. Activation of catabolic pathways. No.
It's correct.
No. I'm correct.
It's correct.
I'm correct.
You
Okay.
see the question
In
is
the
deactivation.
which does not occur in the fed state. So in the fed state, what occurs? Right? In the fed state, in the fed state, my insulin increases. Insulin is an anabolic hormone encouraging storage and biosynthesis. because there's a lot of glucose, I can just take some away. At the same time, I deactivate the catabolic pathway because I don't need to break down my lipids and skeletal muscle.
Yeah, but
Yeah,
it's
but
does.
Activation.
Yeah, it's
Okay, fine.
Oh,
My bad. Okay, I'm sorry. Yeah, okay, can.
Bastard state.
Well, I don't know whether this question wrong also.
Oh.
Oh my god.
Oh.
No, this one should be.
I don't know.
I don't know if you'll answer.
Brain like brain like.
When they counting down, then my
Then you're like,
Okay, so in the fasted state, I have a low insulin glucagon ratio, so I activate my catabolic pathways. Okay.
wait,
okay.
okay.
My,
Wait, what is it?
okay. I put the wrong answer. Okay. You have to understand, I prepared this after midnight last night, so I think I confused it. I'm sorry, but we get the point, right?
Yeah.
Okay.
I'm confused. What?
You're confused. Okay.
Does not occur.
In the fasted state,
Shit, I chose the wheel of
in the fasted state, low insulin glucagon ratio, I activate my catabolic pathways, I deactivate my anabolic pathways. And this
I picked what
No, wrong.
can I?
So it's orange or orange or
Hey, you saw
So the correct answer should be blue. Okay.
What the?
So I just put this here for you all to refer to next time. Okay, so this is just like how you can study biochem. So for me, like I like to take the formula booklet, right? Then I just write down everything into the formula booklet, because then I have the booklet in exam, then I can visualize what it is. But in reality, right, actually all you need to know is this big picture here. So you just annotate this big picture, right, and you're kind of done already. These are all the key enzymes you need to know. Okay. Did I get this wrong?
Yeah.
Yeah, okay. We just swap the two around, okay? Okay, can. So okay, but what I wanted to point out, right, is that a good way to remember like whether the enzyme is phosphorylated or desphosphorylated, right? To activate or inactivate it is that in the fat state, when you have high insulin, all the enzymes are dephosphorylated. So those that work against the catabolic pathways will be deactivated, and those that work for the anabolic pathways will be activated. You get what I mean, right? Can So this is a key principle I need to know.
I thought for some enzymes, when you phosphorylate, you're actually activating.
Yes. So that's exactly. So it depends on whether the enzyme, right, is part of the catabolic or anabolic pathway. So when you have a fat state, high insulin, all the enzymes are dephosphorylated. Then depending on whether you're catabolic or anabolic as an enzyme, right, that determines on whether you're in activated or inactivated state. That's the point I'm trying to throw across here. I'm sorry for the confusion here. Can? Okay. Can. Okay. So now we move on to question 1. So what are the metabolic functions of insulin, cortisol, and adrenaline, and when are these hormones secreted? Okay, I think I got a Kahoot question for this. Okay.
I mean, 0.
Yeah.
Shit. I left the game.
You really skip my story.
I'm tight with blonde.
Me.
Choosing
a wrong answer.
Everyone else. First,
Yeah,
everyone's
law
zero
school.
also. I'm out of the game.
Yeah. Okay, so remember insulin is an anabolic hormone. So these other 3 hormones, right, are catabolic hormones. Okay, so we come back to this thing. When are these hormones secreted? So we talk about 2 situations. One is when blood glucose is too low, one is when blood glucose is too high. Okay, so when blood glucose is too low, which enzymes are secreted? Glucagon. Okay. What else? Okay, very good. Yeah, so these are the three hormones that are secreted when glucose is too low, and conversely, when it's too high, then insulin is secreted. Okay, so then now the question is, where are all of these hormones secreted? So I think if you look at the diagram on the right, that gives you a very good picture which secretes what. Okay,
Is thyroid secreted also?
thyroid doesn't respond to blood glucose, so blood glucose is not a trigger for thyroid secretion.
Where I see the hypoglycemia.
Okay. What? Say again.
I saw something on the CS notes, hypoglycemia related thyroid. Was it cortisol? Okay, never mind.
I don't think so.
I think I read wrong.
It's not I forget, right?
I don't know.
Okay, can. Okay, so cortisol is also an immune suppressant and anti-inflammatory. Okay, so cortisol will potentiate epinephrine, and epinephrine will inhibit insulin. So this is what happens when glucagon is too low, when blood glucose is too low. Okay, so every time you are asked to describe the metabolic functions of a hormone, right, you need to talk about its function with respect to the liver, skeletal muscle, and adipose tissue. So I think we're all tired, so I won't belabor the point, right? But basically, you can. This is a good way to classify and break down all the processes that you have learned. So if something is catabolic, then it will do certain things in these three organs. If something is anabolic, it will perform certain functions in these three organs. That's the point I'm driving across. Any questions so far? Okay, then we move to diabetes mellitus. Okay, so this look familiar to you, right? So the question now here, right, is which one is type 1 and which one is type 2? Okay, that's the next Kahoot question, I think. Are you all reconnected? Can I know you want to win lah, but okay. Okay, I'm sorry the app like a bit screwed up. Okay, but anyway, yes. Was anyone confused by this question? If not, we can move on. Okay. Sorry, my mouse. Okay, next question. What? Who's Josh? Okay, which process represents a type 2 diabetes picture? Type 2, Okay, very good. Okay, I'm sorry. So this is the blown up picture lah. So the type 2 is the right side, type 1 is the left side. Okay. So remember in the difference between type 1 and type 2 is that type 1 has complete insulin deficiency, whereas type 2 has partial insulin deficiency. It's an insulin resistant state with partial insulin deficiency, but I'm still producing insulin. So it's actually written. I'll leave you all to go and digest this flowchart on your own, right? But the key, right, is actually this box in the center over here that says partial insulin response prevents ketosis. So the reason why a type 2 diabetic patient usually does not have diabetic ketoacidosis is because you have some partial insulin response here that will prevent the conversion of your fatty acids into ketone bodies. Whereas in type 1, because insulin is completely deficient, it can be produced. Okay, so I think I've just given away the answer, but the next Kahoot question, right, was what's the name of a type 1 diabetic emergency? Okay, very good. Can answer this one, no problem. Where's my mouse? Okay. Oh no. Okay, never mind. Okay, so diabetic ketoacidosis is type 1. never mind. Okay, then the other one is hyperosmolar hyperglycemic state. Can Okay. Okay, never mind. Okay.
Can I ask,
Yes.
when you have lipolysis, the fatty acids and cholesterol they separate. They separate one in, so they just go straight into the bloodstream.
Yes.
So can fatty acid just travel in the bloodstream without any carrier?
Yes. Can. Okay. Yeah. So my point here was there's two different kinds of diabetic emergencies. One is DKA, one is HHS. In a typical setting, HHS occurs in a type 2 diabetic and DKA in a type 1 diabetic. Are we clear on this? Okay. Now we go to the case. Xin Tong, you want to summarize the case for us? Just say the important points out. Okay, never mind. Then Yu Tong, tell me the important history.
Okay, 65-year-old man.
Yeah.
He has been vomiting,
Yeah.
diarrhea, fever, abdominal pain for the past 24 hours.
Yeah.
History of type 2 diabetes. For diabetes mellitus, forgotten to take his insulin injection.
Yeah.
For 1 day, 24 hours. So, being progressively more agitated and drowsier over the past 12 hours.
Yeah.
So, breathing deeply and rapidly, drowsy, blood pressure of 90/60, heart rate 140, temperature 38.5, respiratory rate 28, oxygen saturation 98% at room air.
Okay, can. So the important point I want to draw out here is he's a type 2 diabetic patient. He's having vomiting, like some kind of gastric infection, right? And he forgot to take his insulin in the past 24 hours. Okay, so just bear this at the back of your mind. Vital signs, can we go through maybe Cheryl, okay. Vital signs, which one is high, which one is low?
Heart rate. High is heart rate, temperature, respiration.
Okay. And SpO2 is?
Low or normal?
It's normal. Okay, it's normal. Okay, then Joy, the renal panel, which just go through that then one by one and then say which one is hyper, which one is hypo, which one is normal.
Sodium is low.
Yeah.
Potassium is high.
Yeah.
Carb is low.
Yeah.
Chloride is low. pH is low.
Yeah.
PaCO2 is low. Serum glucose is high.
Okay, very good. Okay, so this is like when you are presented with this kind of picture especially in an exam setting, it can be quite difficult to digest, right? So I'm going to break it down for you one by one. Okay, so we are going to start right by looking at these 4 components. So we are jumping now to question 4. Offer an explanation for the acid-base status of the patient and calculate the anion gap. Okay, so whenever we have some kind of an acid-base disorder scenario, right? We always apply these 4 steps sequentially. Okay, so the first one, you all just tell me like, is he acidotic or alkalotic? Acidotic. What is the normal pH? 7.35 to 45. Okay, very good. Okay, so we know that he's acidotic now, and now we need to find out whether he is respiratory acidosis or metabolic acidosis. Do you all know how to tell? Okay, like who here, right? When you all learn about this thing before, you all like a bit confused about it. So we can just skip through. Okay, never mind. I'll go through one by one. So we start from first principles, right? Bicarbonate is an acidic or alkaline ion? Alkaline ion. And carbon dioxide is a
Acidic.
okay. Okay. So does this right picture on the right look familiar to you all? This one was from Respi Physio, right? Okay, so what I wanted to point out here, right, was that it is your hemoglobin that usually buffers all the excess hydrogen ions or acids in your blood. And when you have too much acid in your blood, then they will come out from the red blood cell into the plasma, and then you get an acidotic state. Okay, that's why usually when you exercise and all you produce lactic acid, you don't get metabolic acidosis because you have a buffer system in your body. Okay, so now I can have acidosis or alkalosis. So knowing that bicarb is alkaline and what do you call that? And carbon dioxide is acidic, right? So for acidosis, what can it be? Like, it's either bicarbonate is low or carbon dioxide is high. For alkalosis, what's the situation? Bicarbonate is high, or the acid is high, or the acid is low, or the alkaline is high. Does that make sense to everyone? Okay. So after this, right, the question then is, what is the compensation? So the brain will detect the acid-base status in the body, and then it will respond to it accordingly. It's what we call compensation. So now we think, right, if in an acidotic state, let's say bicarbonate is low, which is also called metabolic acidosis, then would I want to increase or decrease the amount of acid in my blood? Increase or decrease? Decrease, right? Because alkaline is low, so in order to maintain a neutral pH state, I need to decrease the amount of acid. Okay, so PCO2 is low. And how do I decrease the PCO2? I hyperventilate. Why does hyperventilation decrease PCO2? Why does hyperventilation decrease PCO2? Because you keep clearing out. Okay, so because carbon dioxide is a more diffusible gas, so when I hyperventilate, I'll expel more carbon dioxide, so that will decrease PCO2. And in the context of metabolic acidosis, what do we call this kind of breathing? Do you all know? Kussmaul breathing. Kussmaul breathing. KAU. Kussmaul. Kussmaul breathing. Can Okay, so this one is from your recipe physio, should be familiar to you. Conversely, if PCO2 is high, I'll compensate by reabsorbing more bicarbonate in the kidneys to buffer the free hydrogen, and that'll be metabolic compensation for respiratory acidosis. Okay, so the question I want to ask, right, for respiratory alkalosis, do you think full compensation is possible? Sorry, for metabolic alkalosis, do you think full compensation is possible? So in the context of metabolic acidosis, I can just breathe very fast until I lower my PCO2, right? But in the context of metabolic alkalosis, in order to increase my PCO2, what do I have to do? Breathe slower and breathe slower. But eventually, I'm going to become hypoxic, right? So that's why full compensation is not possible for metabolic alkalosis. Yeah, Okay. So these are all the concepts that we have gone through. The first principles are on the right, and therefore, if you look at this thing, right, if both are low, it's either respiratory alkalosis or metabolic acidosis, and both are high, it's the opposite lah. You all read for yourself. So this is just a pattern that you all can take home. Any questions? Okay. So next, we have identified that the patient is currently in what kind of acid-base status? Like Joy. Acidosis. What kind of acidosis? You look at his he's in metabolic acidosis, right? Because his bicarb is low and his PCO2 is low. Correct, right? Okay. So it's in metabolic acidosis. So now the next step for us to do, right, is to find out why is he in metabolic acidosis. And this is where the anion gap comes in. Okay. So the principle for the anion gap, right, is that in the blood, electron neutrality must be preserved. So the amount of cations must be equal to the number of anions. Okay. So can someone just shout out to me? Maybe Sunday, I forgot your name. Chanel. Okay, Chanel. Can you tell me, right? Like what's the formula to calculate anion gap? So anion gap equals. Like you just look at it. You just look at this diagram, right? You can work it out. Anion gap equals.
Cation minus. It's Na plus minus Cl minus CO3 minus.
Correct lah. Yeah, correct. So this model, right? This primary school thing. So anion gap equals Na minus HCO3 minus Cl. And what is the normal anion gap? 12 to 16 millimoles per liter. So you all should remember, okay? Normal anion gap is 12 to 16. Today, half of the M2s could remember still. Half of the M2s forgot already. So yeah.
Only one and two could remember.
No, it wasn't just me. No. Okay, where wrote it to 12? Really? Yeah, I don't know. My notes wrote 12 to 16. I'll go and look it later.
I think George is correct.
I'm sorry. Okay, yeah, you all flag this up. Lah. Okay, so normal anion gap is that. Anion gap is only useful in the context of metabolic acidosis. This is a formula. So why is it only useful in metabolic acidosis? We can look at that now. Okay, so in a situation of metabolic acidosis, my bicarbonate is increase or decrease? Decrease. Okay, so my bicarbonate is decrease. So in order to compensate for the decreased bicarbonate, what must happen to my chloride?
Increase.
It's either my chloride increase, like that, or my anion gap increases to fill the gap.
Cannot any plus with no.
No.
Okay.
The cation is the independent variable here. Okay, so we just I mean, of course there are situations where the Na does decrease, but when we look at this, usually it just stays the same lah. So again, right, bicarbonate decrease, it's either the anion gap increases or the chloride increases, right? And why is this important? Why is it important to know the anion gap? It's because it points to the etiology of metabolic acidosis. You know what's etiology? It points to the root cause of metabolic acidosis. So you can tell me what is the cause of the metabolic acidosis in the patient. In the context of unmeasured anions, what are some examples of unmeasured anions that you all can think of? Yeah. What forms the anion gap?
We're talking about oxalo
Anions. Okay, it's all these things. Okay, your lactate, your ketones, your urea, your drugs. These are the main. Like, okay, so why there are anions, right? It's because this, like, say lactic acid, right, when it enters the blood, then the H plus dissociates, right? So it forms lactate. So that is the anion we're talking about. So in the context of metabolic acidosis, in, let's say, a patient who just ran a lot and finished a marathon or something like that, then he has a lot of lactic acid built up in his body, right? So his anion gap will be increased because there's a lot of lactate that's circulating in the blood. Ketones, urea, and drugs are other causes. Okay. Conversely, if the anion gap doesn't increase, then the chloride has to increase, and the chloride will increase when there's a loss of base due to either renal or non-renal causes. This one I will give you all a link, right? You all can go and like read up on your own. But I don't think you really need to know this until like M3. Okay. So we're going to zoom in on the hidden acids now. So for this patient, right, if you look at his chart, right, he's in metabolic acidosis that is partially compensated with his Kussmaul breathing, and at the same time he has an increased anion gap. So now the question is, which anion is increased? Because by knowing which anion is the one that is increased, right, we can tell what is the etiology. So if lactate is increased, it means it's lactic acidosis. If ketone is increased, it means it's ketoacidosis. If urea is increased, then it's, I can't remember the name already. Yeah, but you get the drift lah. Okay, so we look at this, right? Serum glucose, serum ketones are elevated. In urine dipstick, we find elevated glucose and ketones. So what do you think is the picture here? What is the cause of his metabolic acidosis? Ketoacidosis, right? Can follow? Okay. So now on question 2, why might the serum glucose and ketones be high? Okay, so we've already looked at the fact that ketones is the one that's causing the metabolic acidosis. So now we're going to take a step back, right, and look at the glucose. So what is the normal range for glucose in the body? Random.
Is wait, less than
7.
Okay, so the random one should be 11 and below. If you fast, it should be 7 and below. Okay. But we're going to go through this one by one because this is going to be very important, not just in Okay, they tested this for us last year, and then I couldn't answer the question. It was like 4
They
months.
tested this like this year also.
Yeah, they tested this year also.
I think they're gonna test every year, so just know that.
Yeah, so I tried to do this in a flow chart for you also because the diagnostic criteria is very confusing. So the principle, right, is that you need 2 independent signs to make a diagnosis of diabetes mellitus. So it's not enough to have just like a raised FPG or a raised oral glucose tolerance test. You need to have 2 two evidence in order to make a diagnosis. So let's go through the scenario one by one. Okay, so fasting plasma glucose, patient comes for help screaming, FPG is above 7. Is the patient a diabetic?
Fasting.
Yes, no, or cannot tell yet?
Yeah.
Cannot tell yet.
Oh,
Okay, so what do I have to do? I have to look at whether he's symptomatic or not. So if he's symptomatic, is he a diabetic?
Maybe.
You can, right? Because remember the rule, right? The rule is that you need two independent signs to make a diagnosis of diabetes. So it's either, if you have, the first sign is FPG is above 7, second one is that he's symptomatic and the symptoms include polyuria, polydipsia and significant weight loss. Then I can diagnose diabetes mellitus. Next scenario, patient comes in for screening, blood glucose above 7, is otherwise asymptomatic. Is it sufficient? Not sufficient. So what do I have to do? Repeat. I have to repeat. So I repeat the FPG, and if it's above 7 again, then it's diabetes. Can I?
Polydipsia is
Increased thirst. Polyuria is increased urine output. Why do you have increased thirst? Is because you urine so much, then you're dehydrated, then you drink a lot. Okay. And you urine a lot because of osmotic diuresis, because glucose is a solvent that pulls water with it. Okay? Can I?
nothing wrong, nothing wrong.
Okay, does anyone remember what is the lower limit for fasting blood glucose if... Okay, it's quite late. It should be 7, sorry. If it's less than 7... if it's less than or equal to 6, then the patient is otherwise healthy. So now, right, we have a situation where I have above 7, I have below 6. So what happens between 6.1 and 6.9? Do you all know?
Pre-diabetes.
So this concept of pre-diabetes now comes into the picture, right? So we are going to consider that now. So patient comes in for screening, blood glucose is within this range. I have to ask him to do an oral glucose tolerance test or another. I have to ask him to do an oral glucose tolerance test, full stop. Okay? And OGTT comprises, like, what are the instructions for OGTT? What do you give the patient? Sugar, how many grams? 75 grams of sugar. Yeah, apparently it tastes very, very disgusting. Like, because it's so super sweet. Okay, 75 grams of sugar, you just drink it down, and then within a few hours they take the bloods again. Okay, so if your fasting plasma glucose is within 6.1 to 6.9, you refer for OGTT. If OGTT is above 11.1, it's a diagnosis of diabetes mellitus. If OGTT is still within the sub range, then it's a pre-diabetes picture. Okay. Don't worry. Yeah, I'll send you the slide also. Can I? Okay. There's another alternative. So sometimes, right, people don't come in with an FPG. They come in taking an OGTT or rapid or random plasma glucose. So they didn't fast properly. So the indication to continue like investigating further, right, is if the random plasma glucose is above or equal to 11.1. Can I? So this is a complete picture. You want to take, you can take picture now. Yeah, but I will also send the slides. 6.9 to 11.1. And then you consider pre-diabetic also. Yes.
So as
Okay, but it's not really well
as you're
defined.
below 11.1 is pre-diabetic.
And you're not below this.
Oh, okay.
Yeah.
But normal people is like below 6.1.
Yeah. Okay, let me clarify. I think so the diagnosis of pre-diabetes, right, is that if your fasting plasma glucose is 6.1 to 6.9, and then after when I take an OGTT, right, it doesn't exceed 11.1, then it's pre-diabetes. Because it showed that when I was in a fasting state, right, I was not managing my glucose properly. That's like the baseline. Are you all clear with this picture? Can I? So please memorize this and know the numbers.
So if you go down to the one, then you retake again fasting blood.
Which one?
The pre-diabetes.
Pre-diabetes, is it?
Is below 11.1.
Yeah. Then no,
Again, fasting blood.
no, you don't need. Then base.
6.1 to 6.9.
Okay, this one. Okay, I think this is a bit misleading, but my point was just that, because of the fact that the FPG was 6.1 to 6.9, it indicates that this patient has an impaired glucose tolerance. So even if the OGTT was still in the normal range, right, this patient is considered pre-diabetic because when the patient is fasting, he cannot manage the glucose stores properly. Okay? I say correctly, right, Bozo?
Yeah.
Okay.
So if you know 11.1, I don't need to do a test.
No need. It's a diagnosis of pre-diabetes, and then you give the like lifestyle advice kind of thing. May want to consider starting metformin. Okay.
Yeah, so basically the OGTT, right, is actually it's the second test, it's the second line test. Because your first time you find out impaired already, right? So you want to find out, is it really diabetes or is it just impaired state? So for the below value, it's just an impaired state, so you just give like lifestyle advice and that kind of stuff. Yeah. Because most of the time when the patients come in, right, they won't. I don't think they do the OGTT straight away. So that's why most of the time it's like the second line test. But of course, I mean you can still do it first. You just have to do have 2 tests. And then just like some FYI, right? So Josh also mentioned that OGTT is you give them 75 grams of sugar, and then you measure the blood glucose, right? So it's actually you wait 2 hours to measure.
Okay, wait 2 hours.
Wait 2 hours. And then another thing is also before you measure, before you do the OGTT, right, you have to take the glucose test first, and then you give the OGTT, and then afterwards you measure after 2 hours.
Okay. Yeah, I gave up on the thing for a while because like it wasn't working very well. I lost my mouse. Okay. I want to go to question. Where is it? Okay, question 14. Sorry. Okay.
Good luck.
Hey, I only want to do the next question, okay? Can I? Can I? Do the next question. So wait, after this. Wait,
I know the answer leh. Wait, what?
Yeah, metabolic acidosis. Okay, this question onwards, we do properly.
Yeah, always present.
Oh, this one. Let's try. Yes.
Okay, yeah, that's good. So it looks like most of you are still okay lah. So this one as it is lah. So beta hydroxybutyrate is what is measured in the blood. Then acetoacetate is measured in the urine. Okay, this is important to know for MCQ. Sometimes also for essay question. Okay, so the next one, right? Okay, so I'm not sure whether they ran through this with you all also because we changed professor, but did they go through this thing called false positives in a random glucose test? So like for example, if let's say I take my fasting blood glucose, right, and it's more than 7, what are some reasons why I may be in a transient hyperglycemic state? Do you all go through this? Okay, if not then we can guess, okay? So come on. So using your first principles, attempt this question.
Okay. It's not easy.
Yeah, I hate it. That's not.
10 seconds.
What's that bottom? Okay. That's good. That's not.
Okay. Okay. So the reason why I pulled this question out, right, was because it was our essay question last year. So let me go there. Okay. Yeah, it means it won't be for this year, but just for information. Okay. So these are all the causes, right? These are all the potential causes for false positive in a blood glucose test. Also known like causes of transient hyperglycemia. So the first one is in malnourishment. So when you're malnourished, you have low insulin glucagon ratio. So your glucagon will activate all your stores to produce glucose, right? So you have transient hyperglycemia. That's the first cause. So this is hyperglycemia, but in a non-diabetic. Second one, increase cortisol. So if you are in infection, which is physiological stress, or if you're emotionally very stressed, right, then you can get increased glucose, because remember cortisol is also an catabolic hormone. Yes. Okay. Other one, side effects of medication. So certain medications do increase glucose levels. So like thiazide diuretics is a common adverse drug reaction. Then glucocorticoids, your steroids, they increase glucose. But in the patient that comes in, so the application of this, right, when the patient comes in and has high blood glucose, before you move to the diabetes mellitus like management phase, right, you have to consider that do they have any of these like indications that can cause like transient hyperglycemia that I need to consider. Then maybe I need to take these things away first and repeat the test and see whether there's a raised glucose again. The last one is a bedridden state. So when you're bedridden for a long time, there's decreased physical activity, you have muscle wasting, and then the muscles are converted into glucose. So transient hyperglycemia. What came out last year, right, was this thing on gestational diabetes. But this was a common confusion point. So gestational diabetes is a proper form of diabetes. It is not a transient hyperglycemic state. Okay, so this is something you need to know. Yeah.
Okay, I don't understand why, like, when you write it like that, I understand, but then, like, what if, like, instead of malnourishment, like, you eat a lot just before they take the test?
But then that will fall under the random glucose test. So random glucose test, the criteria is more than or equal to 11.1 is suggestive of possible diabetes mellitus. Because if you just ate, then it's considered like glucose, because you were just given a glucose load. So it falls under the RPG criteria. You get it? Can I? Okay. So come back to this question. What is HbA1c? Glycated hemoglobin. And what is glycated hemoglobin? Why is it useful?
Average. 120 days average.
So it indicates the average level of blood glucose in the past 120 days. And why specifically 120 days?
Lifespan of red blood cells.
Okay, very good. Okay, so you all know your stuff. And what is your HbA1c target in a diabetic patient? You all know? It's less than 7%. Okay, less than 7%.
Does it do anything? Like if you have a lot of HbA1c.
It is not harmful to you. It's just that it's indicative for the doctor whether the patient has been compliant or not. Because if I fast before I see the doctor and then like I took my medications like 3 days before seeing, my fasting blood glucose will be very good, but my HbA1c will be high. And I think something for you to take note, right? In the West now, HbA1c is being used as a criteria for diagnosis of diabetes mellitus. Why it is not yet used in Singapore, right? It's because Singapore we have a multi-racial society. So the standards for what is a high HbA1c in a Chinese, in an Indian, and in a Malay is different, and it's not validated yet. So that's what they're still trying to work out now. Okay, but over the next 10 years, you can expect this to become part of the criteria. Okay, so we talked about this. The patient is in diabetic ketoacidosis.
Sure. Does the binding of the
Glucose.
glycation, the AGE, right?
Yeah.
Does it affect the function of hemoglobin, or it just like binds there?
No, it doesn't affect the function, but it just binds irreversibly to hemoglobin.
Oh.
Yeah. The AGE, right, is the advanced glycation end products, right? That one is what causes all the micro and macrovascular complications of diabetes, such as your peripheral neuropathy, your diabetic retinopathy, because all these advanced glycation end products, they are like free radicals. You can think of them as free radicals. They harm the structures.
Just know they harm the structures, lah.
Yeah.
Like just know they harm the structures.
Okay.
Oh yeah. Also, in the diabetic patient, right? Joshua mentioned there's the 3 types of ketone bodies. Then one of them is the acetone. So normally, where do you think y'all can find the acetone?
Breath.
Yeah, okay, correct.
Okay. Very good. Okay. We can do the next question. So everyone log on. So this is about renal physiology lah. Five seconds, 4 seconds, 2, 1. Okay, very good. So, does anyone have any doubts about this? In a healthy patient, the GFR, like the glomerulus thing, all glucose is filtered but then reabsorbed. So the next question then is, sorry. What is the name of the transporter that facilitates glucose reabsorption in the renal tubules? Five seconds, 3 seconds. Okay. Okay, so we have a bit of confusion here, yeah? Okay, so who chose GLUT2? Okay, why do you choose GLUT2?
I don't know.
Do you have a rationale or you just felt? Okay, so
it's present on both apical and basolateral membranes.
GLUT2.
Yeah, I think so.
I thought it's SGLT.
I thought SGLT is only present on one side.
Oh. Okay, but the main one is SGLT lah. Okay, according to I was looking at Costanzo's I don't know about the GLUT2 thing, but SGLT is the main one that facilitates the reabsorption. Perhaps because it is the limiting reagent thing. Because GLUT2, if you have a lot of GLUT2, then it will just allow it to flow through. Okay, so yeah. So we went through this. The name of the main transporter is SGLT. So, can someone explain to me what is the concept of transport maximum? Chanel?
Transport maximum.
Yeah. You all heard of it before? Okay, then since you heard of it, what is it, Terence?
I think it's like the maximum amount of like plasma glucose concentration whereby that there won't be any glucose that will be excreted out of in the urine.
Okay, yeah.
Yeah.
That's correct lah. So it's a maximum amount of the substance that when filtered can be reabsorbed by the system. So what is the transport? Okay, that's the next Kahoot question. What is the transport maximum for glucose? You all need to know this number lah. Okay.
Oh, I can't
Parents
click.
first
I can't click.
Kill me now.
If you're smart, you can look at the graph also lah.
Yeah.
Shit, I think I should.
Okay, so it's 350.
Oh.
It's 350. Why you Did you get it wrong? Okay, yeah. So the transport maximum for glucose is 350 mg per dl. Full stop. This is the one number you need to know. In Costanzo's physiology, they also teach you this thing called the renal threshold, and they explain like why there's a difference between the renal threshold and the transport maximum. They call it a splay, and they account for it. But you do not need to know this, and I do not completely understand it, so I will not try to explain it. But what you need to know, right, is that therefore, when the answer to this question, why are there glucose and ketones in the patient's urine, is because serum glucose concentrations and ketone concentrations exceeded the transport maximum for its reabsorption, causing it to be excreted in the urine. Is everyone clear? Okay. Was I too fast? Anyone want to see the thing? Okay, can. Okay, so now we talk about electrolyte balance in diabetics. Okay, so I think Prof. Ban went through, if you like, in diabetes, then sodium, potassium, then the concentrations, they will be skewed, right? So the thing about this is that it's very tricky because there's no hard and fast rule to this, because in different, what Prof. Ban went through with you is like in a normal diabetic patient without any other complications like concurrent infection or anything. But remember, our patient is having an infection now. So we need to go back to basics, right, and look at what are the factors that increase sodium concentration and what are the factors that reduce sodium concentration. Okay, so factors that increase sodium concentration quite naturally will be free water loss. So when I pee a lot, which is diuresis, then water is lost, but sodium stays inside the body, then I get increased sodium concentration. Factors that reduce sodium concentration is either that is because the sodium you pee it out together with the water, or there's this thing called the dilution factor, where water shifts from the intracellular space to the extracellular space. So these are factors that can reduce sodium. Okay, we look at potassium now. So potassium is actually the same thing actually, but the only difference, right, is that for potassium, there's this phenomenon where potassium ions shift from intracellular to extracellular space in metabolic acidosis. Do you all remember why? Okay, why, Yu Cong?
They say it just swaps from the H plus will swap with the K plus.
Correct.
the
Correct.
cells.
Correct. So the H plus will go into the cell, the K plus will come out, and basically because you want to maintain electron neutrality. Okay. Yes.
Can I ask talking about like muscle spasms and stuff, why do you always look at high
Potassium.
potassium instead of sodium? Because I thought sodium is also used in the action potential.
Okay, see, right? For the action potential, what maintains, you need to know what maintains the basal sort of the the polarized state. Because you know at first it's a negative, right? So there's the potassium. Okay, so you know there's one side, there's the leaking of the potassium from the inside to outside, right? Because potassium mainly is concentrated inside the cell. Then you know when you have your NAK, ATPase, whatever crap, then action potential, then the sodium floods in, then it goes out, right? So that's the basal one. So the thing is, the NA, you need to know for, in general cases for most of the muscles, for most of the like nerves, like whatever, not the cardiac one, the one is a bit special. So in general, talking about skeletal muscle, the upstroke of the action potential is caused by, I think it's the sodium, right?
Yes.
So whereas the basal, then you know after you have the upstroke, then your ion, everything, leak out, whatever crap, then go back to the basal thing. That basal thing is mostly maintained by potassium. So that's why whenever you have potassium disturbances, right, the potassium, the basal electric gradient thing, right, would either be closer or like higher. So if it's closer to zero, then it's easier to excite it, right? Then if it's further away from zero, then it's harder to excite it. But of course, if you have too high potassium or too low potassium, you also got some muscle cramping. It's like that one. Yeah. But you just need to know potassium is responsible for the basal potential. The resting
potential.
potential. Yeah, that's the
Potential.
word I was looking for.
Yeah. And then the distance between the resting and the threshold potential will determine how excitable the cell is. Okay? Yeah, I suddenly forgot all those things. But thanks, Moto.
Yeah, I think that one to move on.
Yeah.
First principles.
Okay. Do I need to go through this? This was covered in Prof. Ban lah. Okay. So the thing that let me think how to explain this. So when you look at electrolyte and fluid derangements in a ketoacidotic patient, you must consider both the total amount and the concentration. So the concentration is what you see and what you get in the results. Then when I look at the concentration, I must then ask myself, is this reflective of the true amount of sodium and potassium inside the blood, or is the concentration being artificially raised or lowered because of like fluid disturbances? So this one is best that when you read it yourself and digest it. Okay? But what I wanted to say here is that our patient is vomiting, right? So because our patient is vomiting, at the same time he's also having free water loss because he's being dehydrated. He cannot have so much water inside. So the dilutional effect of sodium, right, will become like dampened down. So that's why if you look at his acid-base levels, right, normal sodium is 140. His sodium is only mildly hypo, whereas in a ketoacidotic patient you would maybe expect it to be like even lower than that, and that's because he's been vomiting, right? So the dilutional effect of the water is a what do you call that? It's reversed lah. Yeah. Okay. Does this make sense?
I
Yes.
thought vomiting your H plus will decrease.
So why is he acidotic? Is it?
Yeah.
So we will go through that at the end of the case. But so far, my train of thought, you can follow through, right? He's diabetic ketoacidotic now based on his acid-base status. And then this is his electrolyte derangements. Okay. So again, we come back to this, right? So he's having a little bit of free water loss because of his vomiting. But the dilutional factor is dilutional factor occurs because glucose in the blood, it pulls water out from the cell as an osmotic solvent. So this far exceeds, so that causes hyponatremia. For potassium, the metabolic acidosis causes K to shift out, so it increases K. Okay? But there are also other explanations for hyponatremia. So if you think of a patient, right, who is without diabetes mellitus, so like maybe Yu Cong, he gets very, very bad GE, then he vomit, right? And ends up in hospital. He can also develop hyponatremia. Do you all know why? Can you all think of some reasons?
Because you also dehydrated that stimulates the RAS system. So
Okay.
you retain NA, you also retain a ton of water.
Okay, but RAS, you retain both NA and water, right? So does that affect the osmolality much?
Yeah, ADH also. When your virus.
Okay, very good. Okay, so for this, right, the prof last year, right, who taught endocrine, he taught us this approach to hyponatremia, which I thought was going to come out, but it never came out. Because he kept emphasizing this, okay? So you need to consider 3 physiological defenses against hyponatremia. So the first one, right, is that you have sufficient fluid delivery to the glomerular filtration barrier, so that water can be excreted. Second one, diluting segment in the kidney needs to be functional. Make sense? And the third one is that ADH must be suppressed, because if I have too much ADH being secreted, then I reabsorb water without reabsorbing sodium, I can get hyponatremia. Is this clear so far? Okay. So possible pathology. So if so we go row by row. So if GFR is impaired, you can get hyponatremia. Likewise, if I use diuretics to disrupt my diluting segment, I can also get hyponatremia. In fact, I have a very high risk of hyponatremia with loop diuretics compared to the rest. Because for loop diuretics, you disrupt that countercurrent multiplier exchange that keeps the medullary osmotic gradient. Correct? Do you all remember this? So the kidney has that medullary osmotic gradient, right? And that's what allows water to be reabsorbed eventually at the distal collecting tubule, something like that. Huh? Distal convoluted tubule, yes. Okay. So if I disrupt my loop of Henle, I disrupt the countercurrent multiplier exchange, I cannot reabsorb water at all. Okay. Then also your low volume states. So when you have excessive volume contraction, or if let's say I have syndrome of inappropriate ADH secretion, right? This can also cause ADH to be increased. The other causes there you all can read up on your own. I won't explain. Okay. So we look at this. The ADH thing, right? I'm not sure whether you all have a full explanation of it, a full understanding of this. But the big picture is that ADH maintains osmolality and angiotensin 2 maintains blood volume. This is what happens in a normal patient like you and me. Because angiotensin 2, it will reabsorb sodium together with water, right? So it doesn't disrupt osmolality. ADH is the main one that if let's say I never drink enough water, I feel thirsty, then that's the one that functions. Okay? But if there's more than 10% drop in blood volume, right? Then this is when volume restoration will take priority over osmotic regulation. Does it make sense? Because it doesn't matter whether or not I'm hypo or hyponatremic anymore. I just want to get enough volume restored so that I can preserve my cardiac output, my circulatory function. So then you have intense ADH stimulation that overrides the opposing effect of the low ECF osmolarity. Is this picture very clear to you? Does everyone understand? Can yeah. The diagram on the right is just my hand-drawn diagram of the entire RAS ADH thing. Yeah. Okay? Yeah, you're looking at it, you can continue looking at it. Okay. So if our patient is in HHS, hyperglycemic state, then these are the electrolyte derangements. Please revise on your own. Okay. Then just now that whole thing about the balance, the balance thing that I drew NA and K, right? Explain in words is over here. So if you forget it, right, you can go and read it yourself. I took it from some NCB, I think. Okay. So now we go to the last few questions, right? What will happen if he's only treated with insulin and nothing else? And how does IV normal saline with potassium make a difference? So to answer this question, right, we must look at what the effects of insulin are. So can some Cheryl, yes. What are the effects of insulin? Yeah.
For glucose, it will increase rate
Yeah, so no, would it increase or decrease blood glucose?
Oh, decrease.
Okay. And then for potassium, would it increase or decrease extracellular potassium?
Increase.
Yeah. Okay. So these are the explanation why it does so. Right, glucose will go down because so firstly, insulin will upregulate your NAK ATPase, so that will cause K to move from ECF into ICF. So suddenly all the K is sucked into the cell, so the blood potassium level drops. Now, number two, insulin also increases GLUT4 expression of skeletal muscle, so I pull all the glucose into the cell. Can I? Any question? Okay, so given all this in mind, right? Chanel, can you tell me why I cannot just give a boluses of insulin like that without?
Oh, what? Sorry.
Okay, given that we know these are the effects of insulin with regards to glucose and potassium, right? Why would it be inappropriate if I just treat with insulin and nothing else?
Because glucose is what's the word? Can take the water or something.
Yeah.
Osmotically active, yeah. Then something about the brain. Then after that, the skull will limit the brain expansion. Okay, so if there's high glucose uptake, because insulin will increase glucose uptake, right?
Yes.
Then glucose will be used for the brain. If brain will need glucose to, as a metabolic substrate,
Yeah.
So if you just give insulin, right, then suddenly the blood glucose will drop.
Yeah.
Then the water, because glucose is osmotically active, right, so the water will go into the brain. But then if the glucose suddenly drop, right, then the water cannot go out. Then it will be trapped in the brain.
Okay. Yeah. Okay. So that's the first one. So you look at the diagram there, right? So if I suddenly give insulin, glucose decreases very, very rapidly because onset action is almost immediate. Okay. So all the glucose gets absorbed into the brain. Okay. With it draws water. So the brain, you get cerebral edema. All the water is now in the brain. At the same time, because all the water is leaving the intravascular circulation, right? So I get a collapse of circulatory volume. So I will suddenly get hypotension. Make sense to you? Can I? Okay, second one about the potassium, right? So remember just now when we were looking at the patient's potassium, was the true potassium normal, low or high? Low, right? Because the patient was losing potassium through the urine, but at the same time, when I look at the potassium concentration in the renal panel, it appeared high because K was being drawn out from the intracellular space into the extracellular space due to acidosis. When I give insulin suddenly, all the K that was drawn out from the intracellular to extracellular space will move back in. So my K, which is already low, will decrease even further. And when I get hypokalemia, what is the most dangerous complication?
Cardiac failure.
Cardiac arrhythmia, and then you die. Is everyone clear on this, or do you want me to re-explain the potassium? I will re-explain the potassium again. Okay, so initially, right? Let me find the slide for you. Okay, so initially, you look at the bottom left-hand corner. My K, right, was being drawn. My potassium was being drawn out from inside the cell to outside the cell because of metabolic acidosis. Because H went in and K came out, right? So this is why when I look at my renal panel, the K appeared borderline high. Okay, but if I look at the total potassium count, the true potassium level, right, is actually low because potassium was being lost because they were peeing it out. Because when you pee out a lot of things, all the solvents get dragged along with it also. So I renal potassium losses, but on my electrolytes panel, my potassium appeared borderline high because of the acidotic shift. Insulin upregulates the sodium-potassium exchanger. So when I suddenly give a bolus dose of insulin, all the potassium from the intravascular space will shift back into the intracellular space. And then I'll get very low blood potassium levels, which is hypokalemia. And as a result of that, I get cardiac arrhythmia, and then I die. Did you all follow that? Xin Tong? Okay or not? Can I? Okay.
I don't follow the part where you say the solvent.
The solver thing. Okay, so my point, right, was that the total potassium in the body, although the concentration is high, it's actually low, and the reason why it's low is because of renal losses. So the patient in a diabetic state, he's peeing a lot, right? So when you pee a lot, the tubular flow rate is very fast, right? So when the tubular flow rate is very fast, there is no opportunity for potassium to be reabsorbed.
Oh,
So it's all lost also. Okay? Okay. So the principle is you always restore electrolytes and fluids first before you give insulin. That's why he gave IV normal saline with potassium first, and then he gave insulin.
Joshua,
Yes.
during the lecture, right?
Yes.
Prof. Ban said something about people with diabetes, right? Usually you give insulin, then you give the potassium also, right?
Yes.
But then he said something about the exception about the renal people, diabetics with renal failure or something.
I think the reason for that, right, is because in diabetics with existing renal failure, right, firstly the polyuria will not be so severe. Because you imagine, like last time let's say I have 1 million nephron units in my kidney that were functional, but in a patient who has chronic renal failure, right, maybe the number of functional nephrons has dropped to 25%. So even though there's that glucose that's pulling water out, right, there's only 25% of nephrons that's functioning, so my polyuria is not so significant to begin with. So then renal potassium losses are not significant. So the total potassium level, right, is actually normal in these chronic kidney disease patients. The other reason why is also because suddenly I lost my train of thought.
The water loss.
No. There's a potassium side to the story also. Okay, but you take the functional nephron explanation first. That'll make sense, right? Yeah. Okay. So we've come to the end of the case so far. Okay, but I think it's time to stop, right, and think back at the whole case. Okay, so in the STJ, right, we learned that usually for vomiting you get metabolic alkalosis, correct? But what did our patient have? He had metabolic acidosis. So that's weird, right? That's the first weird point. Boto will go through why vomiting gives you metabolic alkalosis later. Okay. Second weird point, right, is that we also learned that type 2 DM patients usually do not get DKA, correct? But this is a type 2 DM patient with diabetic ketoacidosis, and that diabetic ketoacidosis was like superseding whatever alkalotic effect that vomiting would have had, right? So this seems to be like some contradiction here. So I will attempt to explain this contradiction now. Okay, so the question now is what tipped the patient over? So I want to bring this concept of physiological reserves. Okay, so I think you all have a CLC on this if they didn't change, but you all just look at this flowchart, right? So the patient is having an infection. An infection, we have increased secretion of cortisol, we have increased secretion of epinephrine, increased secretion of growth hormone, and these are all anabolic or catabolic hormones. Catabolic. These are all hormones that will increase blood glucose, correct? Okay, so in a healthy patient like Ritong, right? If Ritong vomits a lot, right? He also gets all these cortisol, epinephrine, growth hormone hypersecretion because he's in physiological stress. As a result, right, his blood glucose will increase slightly. Then he maybe will have a little bit higher ketones than normal, but it will still be within normal limits, right? And this is because he has physiological reserve. His insulin pathway is still functioning, right? That can help to regulate the entire metabolic pathway. However, in this patient, right, this is a type 2 diabetic patient. So to begin with, he has poor physiologic reserves. So his ability to withstand noxious stimuli, right, is impaired. And then on top of that, now he has infection. So because of the infection, right, then if you look at the entire pathway, that's how he will get the diabetic ketoacidosis. Do you all understand this? Okay, so our patient now, right, he has relative insulin deficiency. So to begin with, he is predisposed to hyperglycemia and all its related symptoms. It is previously well controlled with insulin, but remember he has stopped taking his insulin for 24 hours already. So in this patient, right, he has a very, very decreased insulin glucagon ratio, because number one, he hasn't taken his insulin as a diabetic, and number two, on top of that, right, he has all of these catabolic hormones that are synonymous to glucagon, right, that are driving lipolysis, that are driving gluconeogenesis in the body. So all these would stack up on one another, right, to give you your metabolic acidosis and stuff.
So it's like type 1 already lah.
Yeah. It's not that he became a type 1.
Yeah, but like
But-
over that period of time.
Yes. The metabolic activity that's taking place is synonymous with a type 1. Because his relative insulin deficiency, okay, like how I like to think of it, right, is like we look at the insulin glucagon ratio. So because of his type 2 diabetic status, he has decreased insulin already. And then with the physiological stress, right, and all the cortisol mimics glucagon action, right? So that ratio is decreased even more because the glucagon in the body is very, very high and the insulin in the body is very, very low now. So there's a much lower insulin glucagon ratio than you would normally expect. And then that's what causes the diabetic ketoacidosis. So it's almost like as if he has no insulin anymore. When you look at that standpoint. Do you get what I mean? Cortisol is a stress hormone, right? So his infection now, you release cortisol, release epinephrine, release growth hormone. Yeah.
Then if the insulin is not low enough, there's something about the threshold. Is it? You cross the threshold. If you don't cross the threshold, there's lipogenesis.
There is what genesis?
There's lipogenesis. I don't know what I'm going to cross.
Okay, yeah. So if you don't cross that threshold, you do not get the ketone body formation because lipogenesis is still
So
functioning.
they occur at the same simultaneously.
Yeah. But then for this patient, right, his functional insulin is much
Lower.
is below that threshold already. So it's within like the type 1 range of insulin secretion. Yeah. This one actually quite difficult to explain, but I hope you all understand. Yeah, and this is my last slide. Okay. Are we all okay? You all can digest? Take a picture, look at it, stare at it, and then I think you'll get to you after a while. Okay, so to summarize, today the key takeaways I want you to have: firstly, catabolic versus anabolic. Classify your hormones based on that, and learn the regulatory signaling and its effects based on those two pathways. Secondly, we learn the approach to acid-base disorders, and we also learn the anion gap. Anion gap is only useful in metabolic acidosis because it helps to differentiate the cause of acidosis. We also explored the causes for electrolyte imbalance in a ketoacidotic patient, and what are the factors that could outweigh each other to cause different kind of electrolyte abnormalities. We also looked at an approach to hyponatremia, which I think you all should remember. Like, never forget this three approach thing, because it is very, very clinically relevant. And then finally, we explored the concept of physiologic reserves, how someone who is a type 2 diabetic in the presence of infection with increased cortisol and having forgotten to take his insulin, he becomes almost like as if he has absolute insulin deficiency, and then he goes into a ketoacidotic state. Okay, so Bottle will take you through like vomiting, right? But and I wouldn't be here for that but I think I wanted to show you this. So a good renal physio is very difficult to learn, but a very good way to learn, right, is to draw out all the transporters in the different parts. Because in your lecture notes, right, they kind of jump a little bit. They don't go through based on the organization of the nephron. So when you learn like acidosis, alkalosis, right, then you'll go back to tell you like what was happening at the PCT with regard to acidosis and all that. So if you draw it out on your own, right, it can really help you consolidate very well. Then every exam you just redraw it. Like now I can remember it a lot better without needing to draw. So it's quite difficult to get this done the first time, but I would strongly advise you all take the time to do it because it can be quite rewarding in the long term. Okay? Yeah, I'll send you all the slides so you all can see. And if you all like want my sample or something like that, you can just PM me, then I'll send. Yeah, just whatever you all want from me that was in the slides, but like you want more, then like you ask me, then I give you. Okay? Yeah. Okay. Yeah. Thanks for listening. Any questions?
Oh, Dr. Derek Soon is a prof which is quite good. Like his slides are all over the place, right? But then when he teaches, it's like next year.
Yeah, he's like super good prof. Like he teaches, it's the way he teaches. So I was trying to teach like him. That's why I got a lot of animation.
But he was a neuro prof, not a biochem prof, so it's like
Yeah.
a bit different.
Yeah.
Oh
Okay.
yeah, but you know, one more thing. George said all the transporters go draw it out yourself, right? Really just go through it because you find in the M2